Hello, my name is Ravi Vij. I'm from My Cancer Haven. And today in the Conversation with Cancer Expert series, we are going to host Dr. Nausheen Ahmed, who's Associate Professor at the Kansas University Medical Center Heme Malignancy Cellular Therapeutics Program. And she's going to talk to us about a very exciting area and new therapies in follicular lymphoma, the CAR T cells. Welcome, Nausheen.
Thank you for having me.
So, Nausheen, if you could give us a little overview about the products that have now got FDA approval for follicular lymphoma, and then we will take them one by one and try to dive deeper into the data and its value proposition.
Thank you. Yeah, so follicular lymphoma, indolent follicular lymphoma, has, it can be, it's a spectrum where it can be very indolent or it can be higher risk and needs to be treated. Such as POD24 or multiply relapsed follicular lymphoma. We have 3 CAR T therapies that are approved in the 3rd or later lines of therapy for follicular lymphoma. And these are outlined here in the slide. In March 2021, we had Axicell approved. Then around a year later, Tisacell was approved in the same setting. And then very recently, just 2-3 weeks ago, we got the 3rd CAR T, Lysocell, approved in this setting. So there's exciting progress in this field.
So what we'll do then is try to take them one by one, and then we'll kind of wrap up by saying, put it all together and tell us how you kind of think about this, not only in the context of these CAR T cells, but in the context of other options that are available for these patients. So let's start off with ZUMA-5, which obviously led to the approval of Axicell or Yescarta. Could you tell us a little bit about this study?
Yes, so the approval was made based on the ZUMA-5 data for Axicell. This was a single-arm phase 2 study in which they had indolent follicular lymphoma patients, so grade 1 to grade 3A. Relapsed refractory follicular lymphoma that had 2 or more lines of therapy, including a CD20 agent, an alkylating agent. The exclusions included transformation or follicular lymphoma 3B, which is treated as an aggressive lymphoma. This study also included marginal zone lymphoma. So there were some patients with marginal zone. However, there were in total 124 patients with follicular lymphoma. The way the trial was designed was a single-arm study. So the patients were screened, enrolled, screened, and then they underwent apheresis. That's where we collect the T cells and then ship it off for the manufacturing process. And then once the cells are ready, then the patients get chemotherapy for 3 days. That's called lymphodepletion chemotherapy. Typically, fludarabine and cyclophosphamide is the commonly used one, and that was used on this trial as well. After the 3 days of lymphodepletion, then they get the Axicell infusion. It's given as an infusion, given as a drip, a one-time dose, and that's it. And then patients were followed up for the primary endpoints of response.
So what did we see in terms of efficacy?
Yep, we saw pretty good results. The ZUMA-5 primary analysis showed response rates above 90%, which was far exceeded what was historically seen, which we'll come to in a bit. But we had a more recent 3-year follow-up for the efficacy, and I have here the responses and survival outcomes. The response rate was 94%, with complete responses being 79%. The progression-free survival, the 36-month rate was 54%. So the median PFS progression-free survival was 40.2 months. Overall survival median was not reached, and the 36-month rate estimated was 76%. The duration of response was 38.6 months. Again, like pretty good outcomes. And the time to next therapy was not reached because many of these patients continue to maintain a response.
So what can you tell us about the side effect profile?
Yeah. So, so the side effects, I went back to the original article as well as the follow-up article. Early toxicities primarily were the hematological, like cytopenias, 70% were cytopenias, and then infections. There are, I do want to mention about cytokine release syndrome, which is commonly called CRS. Which again, for those of you that may not be familiar with it, it's where the immune system is just revved up and patients might experience like a fever, maybe low blood pressure, low oxygen levels. So grade 3 or higher CRS was 7%. And that is usually treated with some special medicines like tocilizumab and other therapies. Now, the other side effect, in particular early on, that we worry about with CAR T is neurotoxicity. And grade 3 or higher neurotoxicity with axi-cel in follicular lymphoma was 19%. So now when we go to late, sorry, when we go to late toxicities, of course, we don't expect to see CRS or neurological events, but we still see some ongoing cytopenias, and then infection remains one of the major risks to contend with even later on.
Okay, so then as far as, putting it in perspective, how does this compare with options that existed before we got CAR T cells?
Yep. So we actually have these publications which compared the clinical trial patients, ZUMA-5, with historical standard of care, which included primarily chemoimmunotherapies in the third and later line setting. So the SCHOLAR-5 study was an international multi-center retrospective cohort study, which reported on what the outcomes were in the third line and later setting. So there was a matched population comparison done, comparing the ZUMA-5 as well as the SCHOLAR-5. And you see the results here. The blue is the responses and CR rates for ZUMA-5, and then the red or the orange is for SCHOLAR-5. So it largely favored axi-cel, although it's not a head-to-head comparison, but it largely favored axi-cel in this setting. And then just going on to, another analysis, I mean, you could ask that, well, those were the clinical trial patients on axi-cel. So what about the real world? How do patients do, those that have had axi-cel for follicular lymphoma compared to SCHOLAR-5? And we see here that even in the real world setting, where we may have patients with more comorbidities or, other issues, and they may not be eligible for ZUMA-5, even in those patients, the response rates were 92%, CR rate 67%, very comparable to the trial. But when we look at compared to SCHOLAR-5, the response rates were 84%, CR rates 37%. So significantly it appears better in the axi-cel population in real world. And this,
yes, this is the PFS and the OS curves.
Yep, this again, as we kind of talked about, this shows the PFS OS for axi-cel and that of SCHOLAR-5, and just tries to compare them. And you see that axi-cel appears to be superior in PFS as well as OS compared to SCHOLAR-5. This also shows the subgroup analysis of those that were over 65 and under 65, and we see that there is efficacy in both subgroups.
And then I guess the next one that got approved was tisagenlecel, or otherwise Kymriah. So what have you got here in terms of the trial design and the data?
Awesome. Yeah, and I call it tisa-cel. So this is we can talk about the ELARA trial that led to the approval of tisa-cel in relapsed refractory follicular. Again, based on another international single-arm phase 2 trial, where we had a similar study population, follicular lymphoma grade 1 to 3A, indolent follicular lymphoma, no histological transformation. There were 98 patients, very similar design to what we saw for ZUMA-5. So patients were screened, they had the apheresis, they had the manufacturing of the CAR T. And then once they were manufactured, patients were then ready to get the lymphodepleting chemotherapy, which was fludarabine and cyclophosphamide. There was an option for bendamustine as a lymphodepletion as well. Once they got the lymphodepleting chemotherapy, then after that, they were able to get the single infusion of tisacel and were then followed up with a primary endpoint of response, complete response.
And so what do we know about the efficacy of this product?
So this product has pretty good efficacy as well. The response rates were pretty high, and the survival, the median survival here was 36 months. In patients that achieved a complete response, their median survival was not reached. Overall survival was not reached for any of the population, even in those who were CR or in PR. The duration of response, again, could not be evaluated, was not reached. And the time to next therapy if you look at the whole cohort of all patients that had either CR or PR and all those, any responder, it was not reached.
And as far as the safety of this product goes?
So again, over here, we'll see that just to summarize this, hematological toxicities like neutropenia, anemia, thrombocytopenia will be the more common AEs or grade 3 AEs. And then we do describe some, in the 3-year follow-up, there were 18 deaths. And I think it's just good to know what are the causes of those deaths. In particular, what were the side effects or any AEs of interest. One was due to metastatic SCC, then encephalitis, pneumonia, so infection, bladder cancer, AML, infection, I think, one case of CRS, and then some other organ dysfunction.
And so this is another option that we have for our patients, and we'll come back to, as I said, all three in a minute. Let's just go ahead and review the last one that is the most recent, which is Lysocell, and its a trial and its data set.
Yeah, so this is the hot news. I mean, this was just recently approved in May 2024 for follicular lymphoma. And this is based on the Transcend follicular lymphoma trial. So this was a multi-center open label single arm study, phase 2 trial. Patients had relapsed refractory follicular lymphoma or marginal zone lymphoma. And for follicular lymphoma, there were some high-risk features that were outlined, especially for second-line patients, because here they did take patients who was second line, whereas the other trials, they were all third or later lines. So in this trial, second line were patients who were POD 24, which means progression of disease less than 24 months from the diagnosis, which is in itself considered a high-risk follicular lymphoma. And those that have been treated, those patients would have had to had an indication for treatment based on the Guelph criteria, such as any symptoms, any B symptoms, any threatened organ dysfunction, any cytopenias due to the lymphoma, bulky disease, splenomegaly. So that was unique in this trial. Now, again, the way the trial, the design was pretty much the same. Enrollment, apheresis, that's collecting the cells go get manufactured. Once they're manufactured, they get lymphodepletion with the chemotherapy, fludarabine and cyclophosphamide, following which they get the CAR T, and then they're just followed up after that.
And what about the efficacy of this product?
So efficacy also pretty good in general. Overall response rates in 96, 97%. We've broken it down here into patients that were second line and patients that were third or later line. And in both these cohorts, we see pretty good results. So overall response rate, 96%, CR rates, 96% for second line. In third line, also overall response rates were 98%, and most of them were CR. Duration of response was not evaluable with a median follow-up of 16 months. Median progression-free survival was not evaluable. Median overall survival, not reached. So
pretty efficacious, it seems like.
Yep.
And I guess anything distinguishing in the toxicity profile?
So in the toxicity profile, Yeah, we've showed just the second line, CRS and ICANS, but then after that we do show second and third line. So if you look at CRS, any grade CRS was like around 50 to 60%, but grade 3 was really low. So most of the cytokine release was just low grade. When we look at neurological events, the total neurological, like any grade, was around 15 to 17%, with just less than 5% grade 3. So in terms of the side effects that we are worried about, like CRS and neurotoxicity, it has a favorable profile. There is a risk, of course, of infections, cytopenias.
Sure.
That I think we have in the next slide. So yeah, risk of infections, although you see that in the second line we didn't see any grade 3 or higher infections, but in the third line we do see some, around 7%.
So I guess now putting it all together, obviously we not only have CAR Ts, we also have bispecifics coming down. And so what is your approach to relapsed refractory follicular lymphoma these days? If a patient is relapsed after frontline, how do you think through it, and how do you choose among the different modalities on this slide and others that you consider?
Thanks. So I think that these are the newer therapies and the upcoming therapies, which you see here, the 3 CAR Ts that we talked about: axi-cel, tisocel, and liso-cel. And then there's a bispecific mosunetuzumab that's approved. And there's some in the pipeline, like epcoritamab, glofitamab, and odronextamab. So when I see a patient with follicular lymphoma that has progressed or relapsed after first line, there are a couple of things you want to see. You want to try to risk stratify them. When did they have the progression? Was it less than 24 months since the diagnosis, less than 24 months since their therapy? Or was it a later relapse? Are they symptomatic? Are they not? What's the bulk of the disease? Those are the immediate considerations about, whether to treat or not to treat. And then, like, perhaps what would we treat with? Would it be trying chemoimmunotherapy again, or would we jump to a novel agent? The lines of therapy would also be important. So if it was just second line, we don't have any, except other than chemoimmunotherapy, like Rituxan, bendamustine, or R-CHOP, or Rituxan with Revlimid or lenalidomide. Sorry, those are the options that we typically have to choose from if we do think that they would be treated as standard of care. In high-risk patients, second line, we still offer a stem cell transplant, autologous stem cell transplant, because there is some data that it has a PFS benefit, especially for those that relapse early on, such as POD24. Now, how does that all change with these newer therapies coming on? There's trials in the second line therapy, like with axi-cel, for example. There's a ZUMA-22 trial with a phase 3 trial looking at standard of care versus axi-cel in second line for high-risk patients, POD24, that have indications for treatment. So I think there's going to be a lot of shift in the paradigm once we have results from those trials. Right now, other than the disease itself, in order to, I would take into consideration patient fitness, comorbidities, caregiver situation, like is it feasible for them to do CAR T from logistical standpoint, or was it, are they too frail for CAR T? Would they benefit with a bispecific, looking at the safety profile of mosunetuzumab? The bispecifics, while it's the risk of CRS and neurotoxicity are less, and it's mostly outpatient, but there's multiple doses, so it's not a one and done deal like CAR T. So everything has to be weighed in terms of the benefit as well as the toxicity profile.
So obviously, these are, however, the bispecific mosunetuzumab and the CAR Ts are directed towards separate antigens, with CD19 being the target for CAR T cells and CD20 for the bispecifics. So I guess you could sequence them and still avail of both potentially in some patients?
Absolutely. Absolutely. So if someone has, like we typically would offer CAR T if they're eligible for CAR T, but if they relapse after that, then we would offer a bispecific. That's typically the way I think about follicular lymphoma.
So you don't have only one chance at it. You can have several shots at it.
Absolutely.
And do we know if any of these have the potential to cure? I know the follow-up perhaps is too short to make that claim, or can we have any inkling of whether these are going to be cures, either the bispecifics or the CAR-Ts?
Yeah, I'd love to see some longer term data, but the 3-year follow-up for axi-cel and tisacel look pretty promising. I mean, there's even with the 3-year, the response, the duration of response and the response rates are maintained in a vast majority of patients. So yeah, longer follow-up is needed, but it's looking good. It's way better than what it was like with the Scholar 5 data, what we saw.
So where do you see the field moving in the future? We've already got a lot of options, and we're kind of hopefully going to be further spoiled for choices. So what does your crystal ball say about where we're headed?
So I'm excited about the paradigm shifting with the CAR-T and bispecifics. In the previous slide, we did see the response rates being pretty high. So in patients that are high risk, which is where most of the focus is, like high risk patients or multiply relapsed patients, but also POD24, I do see a more evolving role for CAR-T as well as bispecifics. And then there'll always be a role, at least presently, for chemoimmunotherapies right now in the first line setting. Although I do see that CAR-T and bispecifics will probably work its way into earlier lines of therapy. For the most, yeah.
That you have on this slide. I said, what about some of the others that you have on this slide?
So some of these, when we think about PI3K inhibitors, ECH inhibitors, we want to see what the relative efficacy, is, and what is the tolerability like of these products. I think that has been sometimes a limiting factor in how often we use these products.
And I think that recently, if I'm correct, zanubrutinib also got approval for follicular lymphoma. As a BTK inhibitor.
Yes.
That may also be one of those
Right.
things. I think, so it seems like the future is bright for our therapies, and patients are going to have a lot of options, and outcomes will continue to improve in this disease that we already have patients often live a decade or more. And I think that from my perspective, I really wish to thank you for your, guiding us through the recent data on the CAR-Ts and how you think through your patients. And I hope I can draw on your expertise in the future to come back and talk to us about new developments in this lymphoma and other areas in the future.
Absolutely. Thank you very much for having me.
Thank you very much for being with us.
All right. Take care.